Welcome to Ask the Expert. I'm Dale Scott, former member of the TMA Board of Directors and a person living with polymyositis with ILD. If needed, you can turn on the closed captions. Click the live transcripts in your toolbar, show subtitles, and then you can adjust the size by going to Settings, Accessibility, and adjust the caption size slider. Before we get started, a disclaimer that TMA webinars are for educational purposes. We encourage you to make all decisions about your care in partnership with your healthcare team. Additionally, speakers cannot answer questions that would require access to your medical records. Please do not put test results and the like in the Q&A or chat. TMA is very grateful for our expert speakers from all over the world. We ask each speaker to disclose any potential conflicts at the start of their presentation. This webinar is being recorded and will be available on TMA's YouTube channel at the beginning of next month. Please put webinar appropriate questions in the Q&A box. Pre-submitted questions are being loaded into the Q&A by TMA staff. Questions put in the chat box may be missed. TMA evaluates its programming to ensure that we are meeting the needs of the myositis community. Please take the survey at the end of the webinar. Thank you. Please check out our new resources section. Note that there are resources available to you. There are resource links, important documents to download, and information for hosts and speakers. Today, we will have Dr. Robert Hallowell, who is the director of the Interstitial Lung Disease Program, medical director of the ILD Collaborative, and of Project ECHO for ILD from Massachusetts General Hospital.
Thank you for having me. It's a real honor and pleasure to be here. And I'm looking at the webinar chat from all the places people are coming from. I'm originally from New Jersey, so hi, Yolanda, and I'm in Boston now, so it's great to see people coming from all over the place. Dale, thank you for having me here today. I do have some disclosures I'll make you aware of. I don't know that they'll be relevant today, but I've served on the advisory boards for Boehringer Ingelheim, PureTech, and Arcellx. I'm an author for Up to Date and Dynamed and receive an authorship fee for that. I've received paid consultation for Vicory and Merck in the past, and I've served on multiple clinical trials over the past decade or so for various industries. I don't get paid directly for that, but my institution does. So if you find something I say to be conflicted, please let me know. I take that very seriously.
So the first question is, I am 81 and was diagnosed with IBM late February. I also have bronchiolitis, Mycobacterium, Avalivium complex, MAC, MAC, and a PO fungus. How will my lung issues affect IBM and vice versa?
Yeah. Well, thank you for that question. So bronchiectasis is a condition where the airways in the lungs are more dilated than they should be. So they're wider than they should be. And you may think to yourself, well, isn't that a good thing, right? Wider roads, more traffic can flow, wider hallways, more people can move down them. So shouldn't we want wider or more dilated airways in the lungs to allow air to move in and out more easily with less resistance? Um, and the problem is with bronchiectasis, these are abnormal airways where the airways in the more distant or peripheral part of the lungs, instead of being nice and tapered and smooth, they actually become dilated and irregular, often slightly damaged. And the reason that's a problem is because it impairs or gets in the way of the lung's ability to clear mucus. And so in these dilated airways, sometimes mucus can accumulate and get stuck down there. Um, and so when you have bronchiectasis or airway dilation, it's a good setup for bacteria to colonize and kind of live in there chronically and set up shop for infection. And so Mycobacterium mac is a type of Mycobacterium bacteria that likes to live in bronchiectasis. And then over time, it causes chronic inflammation that can make bronchiectasis worse. So it can become kind of like a chicken and an egg situation. We also see bronchiectasis in patients who have interstitial lung disease without infection because the inflammation or scarring of the lung puts stress on the airways and kind of pulls them apart a little bit. And so instead of being small, they get kind of pulled a little bit wider. Um, the way that'll impact inclusion body myositis is that when you have any kind of lung condition, whether it's bronchiectasis or interstitial lung disease or even asthma, um, that'll affect the breathing and it might make the breathing a little harder. It might cause a chronic cough, et cetera. And that's just one more thing that might make it more challenging to deal with the ins and outs of inclusion body myositis. Unlike the other myositis, dermatomyositis, polymyositis, inclusion body myositis by itself is not typically associated with lung disease. It typically does not cause interstitial lung disease. And so in my practice, I don't see a lot of patients who have inclusion body myositis per se with lung disease. However, one of the things that can happen with inclusion body myositis is issues with swallowing or weakness of the swallowing muscles. And with that, you can have worsening aspiration or food going down the wrong way or saliva going down the wrong way. And that's a process that also gets worse with aging. And so the older we get, the more we have that issue, whether we have IBM or not. And so chronic aspiration and things going down the wrong way, that irritation in and of itself can also damage the small airways and cause bronchiectasis. So these things all kind of tie together. And so in a specific case, someone in their 80s with inclusion body myositis, whether there's swallowing muscles be affected or just age related, that can cause bronchiectasis and lead to the mycobacteria being there, or the mycobacteria alone could set up shop and cause the bronchiectasis, and then it kind of becomes a vicious cycle. And so that's, I think, how all these things can play together. Hopefully that answers your question.
Okay. So the next question, are there any new developments in treating restrictive lung disease, RLD?
Well, that's a broad topic. I'll try to break that down a little bit. So restrictive lung disease, restriction of the lungs, really can refer to any process that makes it harder to take a full breath or a normal sized breath. We can see restriction in patients who have skin thickening in scleroderma. We can see restriction in patients who have interstitial lung disease because the scarring of the lung or the inflammation of the lung makes the lung stiffer. And so every breath is a little bit more work. And so each breath is a little smaller than it should be. So we call that restriction, and it shows up as restriction or smaller breaths on the breathing tests. And we can see restriction in patients who have inclusion body myositis or the inflammatory myositis like dermatomyositis and polymyositis, because the respiratory muscles, if they're affected, they can be a little bit weaker. And so if you don't have the strength to take a full breath, that's going to show as a restriction on your breathing tests. So it really depends on what the cause is. If there's restriction from a skin thickening, then the question is, well, do we have better treatments to treat skin thickening from scleroderma or scleroderma myositis overlap syndromes? And so there the answer is yes, there's a lot of active research looking at new immunosuppressions and new therapies that maybe are better or more effective at trying to loosen thickening skin. In terms of restriction from lung disease itself, disease inside the lung, whether it's fibrosis or inflammation, that gets a little more tricky and nuanced. Inflammation, yes, I think we sometimes can do a somewhat decent job at reducing inflammation, whether through different types of immunosuppression or steroids. The more we can reduce the inflammation, the softer the lungs can become, and some of that restriction can improve. Fibrosis is a little harder. All types of fibrosis currently are thought to be irreversible. We don't have good therapies yet that can reverse fibrosis or scarring, at least based on our phase 3 trials. I know there's a lot of research going into this and early phase trials looking at trying to break down scar tissue or reverse scar tissue. So it's a very active and hot area of research now. Restriction from muscle weakness. Working on reducing muscle inflammation and treating that aspect of the myositis is important and will help the size of the breath a patient can take. And muscle training. So strength training, physical therapy, pulmonary rehab to strengthen those respiratory muscles can improve the size of the average breath and therefore reduce the perceived restriction that we see.
Okay, thank you. Is the diaphragm ever implicated IBM, and what is the treatments for it?
Yeah, so we can see diaphragm involvement from any myositis. And so maybe IBM less than the other myositis, but all myositis, any muscle condition can affect the diaphragm. And when it affects the diaphragm, depending on the extent that it affects the diaphragm, it can cause profound shortness of breath because the diaphragm is the primary muscle of breathing, especially if it involves both sides of the diaphragm concurrently. And so shortness of breath, that can be a cause of restriction because that's sort of one of the respiratory muscles. And so shorter, more shallow breathing, and patients perceive that as shortness of breath. And so the treatment, certainly with the inflammatory myopathies, dermatomyositis, polymyositis, we try to treat the underlying muscle disease with immunosuppression, with IVIG. Inclusion body myositis is a little bit harder to treat. I'm not an IBM expert in terms of therapies and response to therapy there. My understanding is it's a little more stubborn in terms of treating the muscle disease. I think at a minimum, respiratory exercises and breathing exercises to try to maintain strength of the diaphragm and to exercise it in ways that are appropriate may be beneficial.
Okay. So, what are the medical implications of long-term use of rituximab and Imuron for treatment of ILD and nonspecific interstitial pneumonia resulting from anasynthetase syndrome?
Sure. So the antisynthetase syndrome is one of the subtypes of myositis where you have myositis and you also have one of the known antisynthetase antibodies in the blood. whether it's JO1 or PL7 or PL12 or OJ, EJ, if you've heard of some of these things. And these patients often can have skin findings, muscle symptoms, Raynaud's, et cetera, some other non-lung findings that go with it. And NSIP, as you referenced, Dale, is one of the patterns of interstitial lung disease, one of the flavors, if you will, that may be described by a radiologist if they see certain shadows in a certain pattern. Although to truly diagnose NSIP, we typically need a biopsy to show that pattern. Most patients with myositis, we're not getting a biopsy. It's not necessary, but sometimes we have one and we can prove it's NSIP. Oftentimes, though, we're just looking at the CAT scan saying, yeah, there's a really good chance it would be NSIP if we were to get a biopsy. So Imuran or azathioprine is one type of immune suppressant we use, as is rituximab. Sometimes we'll use both of those together synergistically to treat patients if one alone is not effective. All of these immunosuppressants can have side effects. Imuran acutely or in the short term sometimes can cause GI side effects, diarrhea, nausea, malaise. It can be toxic to the liver, so we monitor liver function, we monitor blood counts. In the long term, there is a slight signal that patients taking that medication, at least in the transplant world, so patients who take it for a lung transplant or a kidney transplant, the risk of skin cancers or lymphoma is perhaps slightly elevated. When we look at patients using that medication for rheumatology conditions like myositis and to treat ILD, the data is a little murkier and we actually don't necessarily see a signal for skin cancer or lymphoma. That being said, because it's suppressing the immune system, and the immune system is sort of our first line of defense against baby cancer cells that are trying to form, we tend to tell patients that if you're on these medicines long term, the risk of skin cancer or lymphoma might be slightly elevated. And so you should get your skin checks, you should get your routine cancer screening, et cetera, just to make sure you're being cautious. Rituximab, similarly, the other thing we can see with rituximab, it doesn't require as frequent lab monitoring because it tends not to be toxic to the liver and kidneys and whatnot. However, there are some patients, rarely with rituximab, where the immune system can get kind of sleepy and produce less protective antibodies in the long term. And so we could see a condition called hypogammaglobulinemia, just a long way of saying hypo meaning low, and your gamma globulins are your antibodies, your immune globulins that your immune system uses to protect you against infections. And so sometimes even after the rituximab infusions stop, the immune system just has a hard time waking up and producing those protective antibodies. And so patients can have a sluggish or weakened immune system for prolonged periods of time, even when they're done with their infusions. That being said, those medications in general are thought to be pretty safe long term, and we do have patients who are on them for years and years, if not decades sometimes, and they seem to do pretty well. So if they're necessary to keep your lungs healthy, to keep the immune system from flaring, it certainly is, I think, safer and better tolerated than long-term prednisone at higher doses, and so that's why we tend to use them.
Okay. So, what types of exercise are safe or recommended, and how can I improve my breathing capacity without overexerting my muscles?
Yeah, so movement is medicine, right? So exercise is good for all of us. It doesn't matter what we have, myself included. We should all try to exercise. Now, exercise for me is going to look different than exercise for you, Dale, is going to look different than exercise for everybody here. And that depends on the state of our lungs, the state of our muscles, et cetera. when possible, it can be extremely helpful to have exercise in a structured and monitored way or a monitored program um, with a physical therapist, with a respiratory therapist to start slow, low and slow, and kind of build up gradually. Um, we do know now that even in patients who have active inflammatory myositis, starting gently and doing isometric exercises, light weights, aerobic exercise is actually good for patients. It reduces markers of inflammation, reduces autoimmunity. It does not cause more damage, which initially was thought to be the case. There's New England Journal papers looking at this. So, so I do think that all of our patients in some form can get some movement and some exercise and strength training. Now, that being said, um, it's important not to overdo it because I think you can
Right.
really be uncomfortable and set yourself back. And so that's where having somebody sort of monitor you and help you with that can be very helpful. Not everybody has that resource. It can be hard to get in. And so if you don't have that kind of formal guidance or don't have access to that, I think starting out something that's easy, easy walking, easy biking, easy swimming, water aerobics, and then if it seems too easy and it's not pushing you or making you feel a little bit tired, then the next week you just push yourself a little bit more and you just very gradually
Mhm.
advance stuff. And I think the key is to write stuff down, right? If you record what you're
Yes.
doing and you have an objective, record of it and you're measuring it, you know what you've already done and whether this is an improvement or a slide, and you have a good way of knowing how you're doing. And it's also motivating. Um, so we should all move a little bit.
Yes, definitely. If one has a diagnosis of DM and anti-PL7AS, how often should they get a pulmonary function test and or X-rays?
Yeah, that's a good question. It depends, like many answers. Um, so dermatomyositis, that antibody is one of those anti-synthetase antibodies. Um, and the answer is going to depend on how stable the lungs are. So, for instance, I have some patients who have myositis and they are very stable. They're on no
Mhm.
therapy because their lungs haven't changed in a long time, and they come in to see me annually. It's not most of my patients, but some of them, and nothing has changed. And so they come in for their annual breathing tests and they get an annual or every 18-month CAT scan to screen for nodules and check things. And that's how often I see them. I have other patients who are actively being put on new therapy. They have very active inflammation in the lungs, and I'm a little more concerned about the trajectory of their condition. Are they responding to treatment? Are they getting worse, et cetera? And so in those patients, I might be getting breathing tests every 2 to 3 months
Mm.
and repeating a CAT scan in 3 to 4 months to see if the therapy is working. And sometimes we throw in more urgent CAT scans if something is changing clinically. There's new worsening shortness of breath we can't explain, et cetera. So it becomes very individualized. Um, X-rays aren't always very helpful for what we're looking for, so we often have to use a CAT scan. And as you might imagine, patients accumulate CAT scans pretty quickly. And so we try to be judicious because they cost money. They expose patients to radiation. They take time out of your busy day, and you have better things to do than to sit in radiology. So we do our best to do them when we need them and not do them if we don't need them. Um, but it really depends on how patients are doing. And the better they do, the more we really try to space that stuff out and see and go by symptoms. But so there's a full range there.
Okay. Um, what questions should I have regular, oh, I'm sorry, what tests should I have regularly to monitor my lungs myositis related lung disease?
Yeah, I think the two biggest things, Well, the three biggest things. One is how you're feeling. Um, I think if we listen to our bodies, um, and physicians listen to their patients who are listening to their bodies,
Yeah.
we can pick up some pretty subtle things. Um, I think part of the challenge is that asking a patient or asking ourselves, are we more short of breath, for instance?
Mhm.
That can be very misleading. Um, and the reason is that nobody likes feeling out of breath. And so subconsciously, we will slow ourselves down so that our shortness of breath doesn't worsen. We never want to feel more than a 4 out of 10 on the shortness of breath scale. So we will start to slow down and not even realize we're slowing down if things are getting worse with our heart, with our lungs. And so I think one thing that is important is to have sort of a checks and balance, whether it's a friend or a spouse or somebody, a child, somebody who's with us frequently, who knows us well, to be an objective sounding board, whether they come to the visit or not, and say, listen, I need you to be my buddy. I need you to watch and notice, am I slowing down? Do you hear me breathing more? Do you hear me coughing more? Because patients often start tuning that out themselves or don't realize they may not feel more short of breath going upstairs or walking in the park, but their partner or friend or somebody may notice that they're just not keeping up as well. Um, and so that objective measure can be helpful. A lot of patients have oximeters, those little finger things to measure their oxygen level, and they may notice a change. Normally they're at 96% and they recover very quickly after they drop with exercise. And now they're sitting at 94 and they take an extra 30 seconds to recover. Those subtle changes sometimes can be the canary in the mine shaft or the warning sign that something is about to change. We want to hear about those things. We take those seriously. So that's the what can I do aspect. Um, how this is all going to change with everybody wearing watches and Aura rings and all that, I don't know. And we're not really equipped to handle that kind of data dump in our clinic. But patients start noticing things and they start getting alerts. And I think when we hear about this, we need to take it seriously because a blip on the radar may mean something. And that's something that's being actively studied. In the clinic, I think to the previous question, and that was a really nice segue there, Dale, as you're monitoring these things coming in. Uh, but I think, we do also get routine breathing tests. And so one of the reasons we're also getting every 6 month breathing test or annual breathing test or every 4 month breathing test, even if the patient feels well. And it's like, well, Dr. Hallowell, do I really have to come for my 6 month visit? I feel great. I'm like, yes, you do, because sometimes we will start seeing very subtle changes visit over visit over visit. And there may not be a statistically significant change from now 6 months ago, but if I go from that visit to 6 months prior and I start looking back over many visits, we start to see that there is a subtle change.
Mm.
Right? It's kind of like boiling a lobster in a pot. You slowly turn up the heat and right. So I,
Yes.
I think all these things together help us. And then we also get CAT scans. If it's every year, every 18 months, et cetera, sometimes we also see subtle changes. So we put all that together and we have a pretty good safety net of catching insidious things that might be going on. And then the big stuff, obviously, patients notice. All of a sudden, my
Yeah.
breathing is worse. My cough is horrendous. I have a new fever. My oxygen's plummeting. I mean, the big things, I think, declare themselves and it's not subtle. Um, so hopefully that answers the question.
Yes, it does. Okay, the next one would be what changes in my results would indicate improvement, stability, or worsening?
Yeah. And I think along those lines, I think looking at some of those metrics, oxygen levels, we use breathing tests a lot to give us a sense of what's happening in the lungs. I know that is a source of great anxiety in our clinic. A lot of my patients don't sleep well the night before their visit, waiting for that breathing test because those numbers mean a lot to them, right? It's a numbers going down means things are getting worse. Numbers stable means things are okay. Certainly, numbers going up seems to imply things are getting better. Um, so a lot of weight gets put on those numbers. Unfortunately, no test is perfect, right? And so there's a lot of, patient effort. How good is the PFT technician? Even time of day can impact
Hmm.
breathing tests. So
Really?
I have some patients who insist on coming the exact same time every visit because they're convinced that their
Wow.
breathing tests are worse in the morning, better in the afternoon, and they're probably right. There is a variation in breathing tests. For most patients, it doesn't make a huge difference, but for some people, it absolutely can. Um, and so we certainly will monitor those numbers. We'll monitor imaging. Um, and so I think these are the metrics we use. On occasion, we'll do things like 6-minute walk tests and ambulatory saturations to see if something along those lines has changed to try to get an objective measure of what the oxygen levels are doing. But even though that's a number, it's also very subjective, as you might imagine.
Mhm.
It's hard to get a
Yes.
true sense of what oxygen numbers are doing. Um, so we put all that together and evaluate it holistically with how the patient's feeling. Um, one thing I'll tell you, sometimes we'll have a patient come in and their breathing test will have nosedived, but they've never felt better. And they just had a CAT scan that is rock stable. Like there's literally nothing changed on it. Their heart is fine. And I'll look at the breathing test and say, well, this is trash. Like there's clearly something wrong with the test. And if you really dig deeply, you'll see that there was, a leak in the system. There was something, they were
Okay.
coughing, they couldn't hold, right. It's just, so there's something there. And so we have to be very careful how we interpret all this data and sort of evaluate it in the context of the person in front of us. Um,
Okay. That's really interesting. Um, the next question would be, should I have a baseline high resolution CT scan, even if my symptoms are mild?
so I think if there is a diagnosis of lung disease or a concern for lung disease of any severity in a patient with myositis, I think having a baseline CAT scan is important. So I do think it's good to know where we're starting from um, in case things were to change or were to worsen. Um, we can tell. Um,
Okay.
Because, I mean, let's say there's only some mild ground glass opacities, as radiologists like to say, some mild
Mhm.
inflammation, et cetera. If we never get that baseline and down the road, something else causes significant shortness of breath, muscle involvement, a blood clot, God forbid, or a heart issue, or other things that can happen to patients. Um, if we don't have that baseline, and then in that setting, the patient ends up in the hospital at the doctor's office and then gets chest imaging, and they see this stuff there, we may falsely attribute those symptoms to the new finding. And so I think baselines are always very important. Baseline breathing tests, baseline imaging, baseline heart studies, because it's very common to have a little bit of valve disease or a little bit of elevation of pulmonary pressures. But knowing what we're starting with can be critically important when symptoms come and go, especially in a complex condition such as myositis, where muscle involvement, lung involvement, heart involvement, and don't forget, people are aging, there's anxiety, there's all kinds of other stuff that happens. Right? Just because we have myositis doesn't mean that we're protected from all the other ailments and misfortunes that are going to come and go that need to be treated and dealt with. So it's good to sort of know what we're dealing with, I think.
Yes. Okay. So how do you distinguish between muscle-related breathing problems or weakness and lung-related breathing problems?
Yeah, that's a great question. And it goes in two directions. So um, sometimes breathing can get worse, symptoms get worse, and breathing tests get worse. And we may think, oh, the lungs are getting worse, when actually the lungs are fine, and it's the breathing muscles that are getting worse, or the skin thickening from the myositis scleroderma overlap is getting worse. And so it can be very misleading on the on standard breathing tests unless we do specialized breathing tests where we do inspiratory forces and expiratory forces, what we call MIPS and MEPS, to figure out is there a muscle weakness component. And so in that situation, we'll often get a CAT scan to see, because if the breathing's getting worse and the breathing tests are looking worse, but the CAT scan is perfectly stable or improved, then it makes us really suspicious that we're maybe dealing with a muscle issue.
Okay.
Likewise, if we can be fooled where sometimes the medicines we use, the mycophenolate, the azathioprine, the IVIG, the rituximab, the prednisone, makes the muscle disease better. And the muscle disease is easier treated, but the lungs are more stubborn. But the patient feels better. They're breathing better, they're taking better breaths, their PFTs look better. And so the pulmonologist may be feeling all smug and happy. But if we were to get a CT scan, we may see that actually the lung inflammation has not changed or improved, or maybe even got a little bit worse. And it was just being masked by the improved muscle function and muscle strength. So we have to keep in mind that the lungs do what they want to do, the skin does what it wants to do, the joints do what they want to do. These things all operate, they march to the beat of their own drummer. And so we have to always monitor each one individually and make sure that we're keeping tabs on them, with breathing tests, with imaging as necessary, talking to the patient, putting it all together. So it can be very complicated. And sometimes we get fooled. And sometimes it takes a visit or us trying something, it's not working, we're scratching our heads. If you want to be humble, treat myositis patients. They will constantly remind you of how little you know
Yeah.
about medicine.
Yeah.
So yeah, it's not a field for the arrogant because it's uh, yeah.
Okay. Which symptoms should prompt me to contact my doctor sooner rather than waiting for my next appointment?
Any, any,
Hmm.
any. If it's on your mind and it doesn't feel right, you should be reaching out. Here's the analogy I would use. You're sleeping in the middle of the night and your smoke alarm goes off. Are you going to lie there and think to yourself, is this a fire? No. Are you going to let your family sit there maybe in harm's way? No. You're going to get up, you're going to get out of bed. It's also loud and annoying, but you're going to check on that, right?
Right. Right.
Maybe it's a false alarm. Hopefully it is. 90% of the time it is. But you're going to get up and you're going to check. You're going to check your house. You're going to make sure that you don't smell smoke, and then you'll turn it off. Um, and I think with this condition, you need to be in tune with your body. If something doesn't feel right, if something doesn't look right, especially when you're on medications that blunt the immune response, reduce fevers, right? Many patients don't ever get a fever if they're on prednisone. Many patients, right, don't have normal signs of infection if their immune system is blunted. Something just doesn't feel right. So if something is not right, you need to be reaching out to your doctor and letting them know. Not 3 days later, but when something starts. And the worst they should say is, I don't know if this is relevant. I don't know if it's important yet. Maybe we just watch. Maybe you don't need an antibiotic right away. Maybe you don't need to change your prednisone right away, but it needs to be on their radar and you need to monitor it. You don't always need to go in for a visit. You don't necessarily need a CAT scan right away, but it needs to be, the antennae have to go up, because it's escalation of symptoms. There is nothing more upsetting than getting a call from the emergency room and learning that our patients are there for 3 weeks of symptoms. Because if we can catch something early, we have a much better chance of nipping it in the bud and preventing really bad flare-ups, which sometimes can be life-threatening. So I would say all symptoms are important and we should hear about them.
Okay. Um, Next question is, I have IBM diagnosed and pulmonary hypertension of unknown cause. Are they related?
Um, I don't know, not having access to your chart. However, typically we don't think of IBM as being related to interstitial lung disease or pulmonary hypertension the way dermatomyositis is or polymyositis is or the other rheumatologic conditions or connective tissue diseases are. Now, does that mean that there aren't cases of IBM overlap with other things? And so I'm not sure in your particular case. But in general, we tend not to make that link.
Okay. Okay. How does antibody status, for example, Jo-1, the PL7, PL12, MDAS, affect lung prognosis?
Yeah, that's a really good question. Something that my research focuses on personally. So I'm I'm biased. I think that's a really interesting question because that's something I try to answer. Um, so the short answer is it does. So we think antibody status can affect prognosis. Um, Now, we're not as smart as we think we are, though. So we think we know a lot about this, and we actually don't. And I think the more we study it, the more we realize we actually don't know anything. Um, and let me expand a little bit without boring you with some of the gory details. Um, we are reaching a point where we think there are different phenotypes or flavors or presentations that some of these antibodies are associated with. However, all of these studies are small and they just look backwards in time through charts. And so it's really hard to say, well, everybody who has anti-Jo1 antibodies, they're going to look like this. And everybody who has anti-MDA5 antibodies, they're going to look like this. And right, so it's tempting to say, well, each of these antibodies has a certain look. Like all golden retrievers act like this, and all pit bulls all act like this, and poodles act like this. And it's just not that simple because there's so much overlap between all of them. And so it's really not necessarily a useful exercise at this point to say, well, if you have this antibody, this is what we can expect. At
Mhm.
this point, we can say, well, you have this antibody. This is how you're presenting. You are you. And we're going to treat you and we'll kind of monitor you for things based on what we think we know about this antibody. And what's been misleading is, for instance, for years we thought that anti-MDA5 was the most horrible of antibodies, and everybody who had this antibody had rapidly progressive interstitial lung disease and they died in the hospital. And that's because the only studies we had were people coming into the hospital. And once they were in the hospital, we would test them and find that antibody. But we never tested people outside of the hospital for that antibody until recently. And so, research that I've done and some of my colleagues around the world have done, we're now learning that there are thousands of people with anti MDA5 who have very mild disease that will probably never progress. And we wouldn't have known if we weren't looking for it. So I think the more we discover and the more we look, we're going to learn that the presentation of each antibody is actually extremely varied. And when you start throwing things like country and race background, it gets even more interesting because different regions and genetic factors, where people are from, that actually changes the impact that these antibodies have too. So I think there's a lot more to learn. Um, So I think the antibodies, they may impact prognosis, but I don't think it's useful for any individual patient to know anything about what their prognosis is going to be based on the antibody for them. Um, and so for now, I think each person has to just live their individual life, have their own individual treatment plan, and we have to kind of take it visit by visit and see what unfolds. And I know that's not useful necessarily. It's sort of unsettling. But I think that's honestly where we are right now with our knowledge base.
Okay, but it makes sense. Okay. Next question is, I've been told that the side effects of the antifibrotic drugs can be severe. Can you discuss this a bit?
Sure. Yeah, I would say as a general class, um, the antifibrotics have appropriately earned themselves a negative reputation.
Mm.
The immunosuppressant drugs that we use, like, Cellcept and azathioprine, et cetera, they tend to be better tolerated. Certainly, I have patients who have had a hard time with those as well. So they're not necessarily always, they're not always a walk in the park, but as a whole, they can be much better tolerated. The first generation of the antifibrotic medications, this is referring to nintedanib, brand's name is Ofev, and pirfenidone, which is the brand name Esbriet. Those up until recently were the two antifibrotic drugs we had. And with some exceptions, I have patients who tolerated them well, but for the most part, most patients who take those have some kind of GI side effect. Sometimes it's mild, a little nausea every once in a while, or the occasional loose stool every once in a while, but not a big deal. But for some patients, it's significant nausea or vomiting or significant diarrhea and life-altering GI symptoms. For some patients, it's not worth it, and it's life-altering, and they just cannot tolerate the medications, and so they have to stop it. A lot of patients, sadly, feel very trapped, and they feel that they're choosing between quality of life and happiness and daily enjoyment and the risk of progression, and that they're backed into a corner. And the most recent antifibrotic, nerandomilast or Jascayd, also has GI side effects. It seems to be less. We've been using it quite a bit. I think it's better tolerated. It was in the studies. In our own practice, it seems to be better tolerated. But there again, I can tell you already we have plenty of patients who are having a significant number of side effects on that medication. So the unfortunate thing is, as a class, all of these antifibrotic or anti-scar tissue medications, just based on how they work and what we're trying to target in the body, they all seem to be causing a lot of side effects. The good news is that it's a very hot area of research. And so a lot of drug companies are putting a ton of resources into finding newer formulations with less side effects, newer medications that work better and have less side effects. So my hope is that now we have 3 on the market, fourth should be approved, and there are many more in the pipeline. And so if we have many options, there's a better chance that for any one patient, one of them will be tolerable. And we'll have several things we can use in combination to try to slow down the process. So I think the future looks brighter, but we're still not in a place where we can treat progressive scarring easily. It's no walk in the park, and I think we have to acknowledge that.
Okay. Okay. Could you tell me what pulmonary rehabilitation is and when is it appropriate for myositis lung disease?
Yeah. So it's a structured exercise program where you go often typically twice a week to an establishment where they have different exercise equipment. So they'll have bikes and treadmills and hand bikes and sometimes rowing machines, depending on the place. And while they monitor your heart rate, and oxygen levels. They have oxygen on site to give you high levels of oxygen if needed to help you exercise and to facilitate that. They have a structured exercise program where they monitor you, they record what you're able to do each visit and show you your progress, and they coach you. And they'd say, listen, Dale, you're biking, you feel out of breath, you're saying, I don't know if I can do this, but you look good, your heart rate's fine, your oxygen levels are actually fine, you're in a safe zone, you can keep going. And that reassurance kind of allows you to sort of push yourself a little bit more than if you were just at your local gym, not knowing what your oxygen levels were, not having the backup of inline oxygen that you could put on and sort of allow you to push yourself a little bit more. And so they give that report to your physician as well. So your physician can see what progress you've made and if there's changing in oxygen needs, et cetera. So they're also a pair of eyes and ears for us. The challenge is when the program ends is sort of maintaining that fitness that you've gained. It doesn't change what happens inside your lungs, but it can strengthen respiratory muscles, strengthen arms, strengthen legs. And so when the rest of the body is stronger, any given activity is less of a chore. And so if you're putting less stress on the rest of the body, you're not as reliant on your lungs. And so saturations can remain higher if your lungs are stronger, et cetera. So you're not increasing the size of the gas tank, but you're getting better miles per gallon,
Uh,
if that makes sense.
yes, yes. So, Dr. Holloway, we're getting to the end of our time. Do you have any final thought for us?
Oh, that's a dangerous thing to ask me, Dale. You. So, um, my family will tell you I always have thoughts. I don't know if you want to invite that. Um, you know, I mean, I've been doing this for, well, a minute now. As we say. First of all, I'm just so honored to be here and in this space, and thank you for welcoming me into your community. I know it's not easy. I haven't walked in your shoes. I'm not living your experience. Um, my hope, and I think there's always hope, is that we continue to advance the field. We continue to learn more. We can, do research, et cetera. But my hope is that research and clinical trials move in a direction where we're actually giving you what you need and what you want and not telling you what you need. And I think right now we're in a place where outcomes for clinical trials and the medications that are coming out are a little bit patronizing in a way that people are just kind of telling you, here, take this. The side effects are terrible. Suffer through it. Maybe you'll live longer. And I don't think the FDA, I don't think outcomes from these trials focus enough on patient-reported outcomes and things that actually matter sometimes in the day-to-day life. And I think that's important. We're starting to see a bit of a shift there, where some side effects and symptoms and quality of life and patient contentment are starting to be baked into these trials and are actually being valued by the FDA. But forced vital capacity is not the only metric we should be looking at here. I think we all want to live better, not just longer. And I think we just need to do a better job of listening and shifting some of that focus. So I think it can be done. We've done it in other aspects of society. But I do have hope. And I think that when I come back next year, if I'm invited, certainly 2 years from now, 3 years from now, I think the medications we're talking about, I think the outcomes we're talking about are going to be very different. And so I've seen it even just in my career. And so I'm not that old, but but I've been doing this well over a decade. But it's been striking the progress we've seen. So thank you for inspiring us. Thank you for your courage. I know, sometimes it takes courage just to wake up and to get out of bed, and just to walk, right? When you feel crappy and your doctor tells you need to exercise, you need to go to PT, and your loved ones are saying you need to do more, Ma, you need to do more, Dad, you need to move. The doctor's telling you to move. And sometimes it feels like that's a chore, and you're allowed to have bad days, and you're allowed to have a little bit of grace and be kind to yourselves. So we hear you. Well, we don't always hear you, but we should hear you. And we'll keep trying to do better. So thank you.
Okay, and thank you, Dr. Holloway, for this evening's presentation. Excuse me. Don't miss these upcoming events. There's one on diet nutrition challenges in July, followed by the Ask the Expert Dermatology edition on July 23rd. And on July 29th, we're going to have an empowerment clinic to help us set boundaries for everyone in our lives. And in August, Dr. Weil will be featured on Ask the Expert. TMA has lots of support and affinity groups to attend. Also remember that early bird registration for Myocom ends on July 1st. And Myocom is September 24th through the 27th in St. Louis. And I'd like to thank to everyone for attending today's webinar. And a special thank you to Dr. Holloway.